on.
It's on. Hi, I'm Abhinav Sidana. Can you guys hear me?
Yeah.
I'm presenting a talk on focal therapy for prostate cancer. Thanks for inviting me. I'm a director of urologic oncology at University of Cincinnati College of Medicine. This is my area of research. This is my clinical interest, and I'm really passionate about it. I hope it's gonna be interesting for you guys too. Okay, I don't have any disclosures. This is the outline of my talk. I'm going to start with prostate cancer incidence and mortality. In 2018, there will be 165,000 prostate cancer diagnoses. So it's a big public health burden. And despite our best effort, the number of prostate cancer deaths have been stable for several years now. It's 30,000. And all these patients get diagnosed. A lot of them get treatment. And despite that, 30,000 people still die. A lot of people get a lot of side effects because of the treatment. So the odds of developing prostate cancer, especially when you're in 60s, is 1 in 20. Pretty high. And once you are above 70, it's 1 in 12. And for all comers, it's 1 in 9. So 1 in 9 men will have prostate cancer. So it is a big public health problem. So among all those diagnoses, greater than 30% of them are low risk. Another 30% are something called intermediate risk, and I'm going to explain to you what these low risk, intermediate risk, and high risk mean. But despite that, majority of the patients end up receiving definitive therapy. They get treatment for prostate cancer, even though 60% of them either have low risk or intermediate risk. And because we treat so many people, a lot of people get side effects. They develop urinary leakage, they develop erectile dysfunction. And as a surgeon, I would like to believe that my patients do not develop these things, but they do. If you, as a surgeon, when you ask patients, the numbers you're getting are different than if you send a survey to the patient and ask them the same numbers. And with surgery, even in the best of the hands, greater than 50% of the patients will be impotent. Greater than 10% of the patient will be incontinent for the rest of their life, even in the best of the hands. And usually in community, the numbers are a little bit more worse. So what is focal therapy? Focal therapy or partial gland ablation is a treatment that aims to eradicate just the known cancer in the prostate and leave the uninvolved prostatic tissue alone, with the hope that this will preserve genitourinary function. And what is genitourinary function? Erections and urinary control. It's called genitourinary function. So focal therapy, by common sense, should be better than treating your entire prostate. It's something similar to lumpectomy for breast cancer. You just remove the tumor, you don't remove the breast every time. If there's a kidney tumor, we only remove the kidney tumor. We don't remove kidneys. Brain tumor, we only remove the brain tumor, not the entire brain. But for prostate, things were different, right? We were removing the entire prostate. The hypothesis is if you remove only the cancer or treat only the cancer and do not treat the benign prostate, which even in most aggressive circumstances, only 30 to 40% of the prostate will be involved with cancer. 60 to 70% will not be. Then if you spare that prostate, you're gonna save the function, which is erections and urinary control. Okay. So this is a study from 4 largest institutes doing prostate cancer surgery. They had more than 10,000 patients and long follow-up. If you see this 20-year follow-up, and in that follow-up, they divided patients into 3 risk categories, and Gleason 6 is the low risk category. And now we know that these patients do not need surgery, and these patients just need active surveillance. Gleason 7 is intermediate risk category, and the third is Gleason 8, 9, and 10. This is the high risk category.
Hey, doctor, what are the scales? I can't read it.
Yeah, so this scale down there is number of years. This is percentage in terms of you start with 100% age, how many people were still alive at the end of 20 years, right? So you start over here, 100% of people are alive at time 0, and then the number keeps dropping down, dropping down. So black is the death from prostate cancer. Gray is the death from other causes. If you see Gleason 6 cancer, there are hardly any deaths from prostate cancer. All these people die of heart attacks, strokes, old age, other causes. They didn't die of prostate cancer. If you come to 7, some of them died of prostate cancer, while others died of their natural causes, which they were going to die anyways. When it comes down to 4 plus 3, 7, so 7 could be 2 different types. One is more aggressive than another type. The more aggressive 7 can cause some prostate cancer deaths, while if you're coming at 8, 9, and 10, those patients die mostly of prostate cancer. They die less of heart attack, strokes, other causes. If you have that kind of cancer at the beginning, then your odds of dying prostate cancer is way higher than dying of natural causes. But these patients, they don't die of cancer. These patients, hardly 2 to 4% of these patients over 15 years, and this is not a short follow-up, this is not 2 years, 3 years, 5 years. This is 15-year worth of data showing these patients do not die of prostate cancer. But you know what all these patients were getting? Prostatectomy. All of these patients were getting their entire prostate out. But now we know that these patients don't die, so we started putting them on active surveillance. And in most I would say urologists who follow the data would offer active surveillance to the patient with Gleason 6s. Rarely you would get a prostatectomy for this cancer now. Gleason 7, but everybody else, right, get whole gland therapy. What does whole gland therapy means? It means treating your entire prostate, either by radiation or by removing the entire prostate. So it's a radical surgery, radical therapy. Do all of these patients deserve that radical surgery? Do they need it? But the death is so low. So these patients, we're doing a good job now putting them on active surveillance, means watching their cancer, not treating them. But I think this middle part should be focal therapy, where you're not over treating them because they're not going to die. So even if you can just control their cancer while they lead their natural life and die of natural causes, that's what you want to do. You don't want to probably take their entire prostate out. You can just, if control their cancer, and even if you leave something behind, as long as they do not die of prostate cancer, I think our objective will be achieved. So that's the category where I think focal therapy will come into the picture and avoid side effects. I think I'm going to just use this.
How to read the citation at the bottom? This is Journal of Urology 2011. What's the 185 and 869?
185 is the volume, and 869 is the page number. Okay, so I'm going to actually switch to this. This keeps skipping. So now, if we knew that these patients do not need that aggressive treatment, why were we just doing prostatectomy on these patients for so long and putting men into diapers, making them impotent for so many years? Because there's one concern: prostate cancer is multifocal. You're trying to treat cancer, but they're not one spot of cancer, they're multiple spots of the cancer. How would you treat multiple spots? The second thing is, even if we know there's a spot of cancer which we need to treat, how to find it in the prostate where the spot is? Is it on the left side? Is it on the right side? Is it up? Is it below? Is it anterior? Is it posterior? It was pretty difficult to find out. So because of those two reasons, we were treating the entire prostate. Even though usually the cancer involvement is less than 25%, we were treating the 100% of prostate. And that's where the rationale for focal therapy comes into the picture now. Now we know over the last 4 or 5 years that even though there are multiple spots for prostate cancer in a prostate, there's one spot which is culprit, which is called index lesion. This is the spot which drives the biology, and this is the spot which will have most aggressive cancer and ultimately will either lead to cancer spread outside prostate or patient's death. It's usually one spot. So that was the hypothesis. And if we can prove it, that this is the spot which is going to lead to patient's death, and identify it and destroy that spot, do we really need to take the entire prostate out? So Dr. Ahmad et al., this is a group from University College of London. They did a study where they had 100 prostates removed for prostate cancer, and they reviewed the entire prostate under a microscope, and they described index lesion as the largest cancer-containing spot in the prostate. And they were trying to figure out if these patients were not getting prostatectomy, how many of them could be a candidate for a treatment localized only to the spot instead of taking the entire prostate out. And they found out that in most of the patients, that one single spot, which was largest in size, also had the most aggressive cancer. The other spots were tiny, and they had least aggressive cancers, the cancers which don't kill patients, and cancers which actually better not be found. Okay, and they proved that if they had known that information before the prostate was taken out, 50% of these patients could probably be eligible for a treatment called focal therapy, where you can just destroy the cancer-containing spot. And this has also been proven afterwards in some basic labs, and it shows that the low-risk cancer, so the blue area is the low-risk cancer, Gleason 6s, which would not progress for 10, 15, 20 years and probably would never be a cause of problem. And the green areas are the high-risk cancers, which are 7, 8, 9, 10. Both do not share any common pattern. The low risk arises independently, high risk arises independently. And if you see the purple circle is metastatic disease. So the metastatic disease, which means cancer spread outside your prostate into your lungs, livers, bone, is going to come from high risk disease. It's never going to come from low risk disease. They proved it with genetic mutation data in a lab. And their hypothesis was, from a normal prostate, you're going to have a common progenitor cell which gives rise to low-risk cancer or high-risk cancer independently. They do not arise from each other. So when we put patient on active surveillance, patients ask me, can this cancer become aggressive down the line? That cancer itself will never become aggressive down the line. You might have a new cancer which is aggressive, so you need a follow-up even when we are watching your cancer, and you need biopsies, you need MRIs for a new cancer. But the cancer, the Gleason 6, will probably never become metastatic. Hopkins did similar study. They had 30 men who died of metastatic prostate cancer, and they got the tissue from all the sites where the mets were, bone sites, lung sites, all the sites where the cancer went. And they did genetic mutation analysis, and they found out that in all these patients, like in every patient, there's usually a single cell in the prostate which caused all the metastatic disease. All the disease outside the prostate came from one single cell. So in theory, if you can identify that single cell before the patient becomes metastatic and destroy that single cell, you can probably avoid all the disease in the lungs, bones, and lymph nodes. Okay, so it's called monoclonal, which means they arise from one single cell in the prostate. So this is just a schematic diagram. So on the prostate up there on the left, there's a low-grade cancer and there's a high-grade cancer. So low-grade cancer will stay in prostate like that for patient's life. The high-grade cancer will change into a separate clone, which is metastatic clone. Clone is a kind of cell which will then go into patient's bloodstream and spread to patient's lung, liver, or bone. So if you could destroy that high-grade focus, then potentially you can avoid that process. Now we know that if we could destroy that spot, we could prevent metastatic disease and eventually prevent the death. right? But how to identify those things? It was not easy to identify that focus. All those studies actually had prostate in the hand from the patients who had prostatectomy, and then they found those parts retrospectively. Nobody could identify those parts before patient was dead or before the prostate was actually taken out. We knew that the kind of biopsy which we do, the random 12-core biopsy where we put an ultrasound in patient's rectum and randomly shoot needle 12 times, we knew it was very inaccurate. Historically, it has been proven when that biopsy says left, cancer sometimes could be on the right side. When the biopsy says there's no cancer on the left side, you take somebody's prostate out and there's really ugly, aggressive cancer on the left side. We had those instances. We all knew that biopsy is not a really accurate way of deciding where the cancer is localized. Until 2007, we did not have that data. In 2007, we started using prostate imaging. This was the first time we could actually see prostate. Like we use CT scan for kidney, or CT scan for pancreas, or CT scan for chest, MRI for brain. We could all visualize those structures without actually having to take them out. Prostate, there was no way to look at prostate without having to take it out. So multiparametric prostate MRI is a kind of MRI of prostate. It's kind of scan for prostate using 3 different characteristics, which helps us identify prostate cancer even without having to take it out. Okay, these techniques help us identify those parts which could be potentially culprit and potentially could lead to patient's death before we remove the prostate. So this is an example of MRI. Do we have a pointer? No? There it is. Okay. So this is prostate. And it has 3 scans of prostate. So this is a gentleman who came, this is from my time at NIH. This guy came at NIH, had multiple biopsies which were negative. And the reason they were negative were because when we do biopsy in office using ultrasound alone, we target this area. This light gray area is called peripheral zone of prostate. We target it. And most patients would have cancer in that area, and we find it. But in his case, his PSA kept rising. He did not have cancer in that area. He had multiple biopsies, all were negative. And that's what we used to do before MRI came into picture. We just kept biopsying them again and again. And then this guy got an MRI which showed he had a large cancer in the area which was not biopsied by regular biopsy. And these are multiple phases showing the same cancer. And he got biopsied and there was Gleason 8 cancer in that area. So this is one of the first publications which actually changed the perception of urologists. I don't know why my presentation is acting funny though. Which changed the perception of urologists regarding MRI. Am I doing something? Is this changing?
Could be.
Or is it that? So that changed the perception of urologists and even the community that MRI is actually a better way to diagnose prostate cancer. And the reason is MRI followed by fusion biopsy diagnosed 30% more high-risk cancer. The cancers you want to diagnose them early and treat them early to save somebody's life. And it diagnosed 17% fewer low-risk cancer. This is the cancer you don't want to diagnose. These cancers lead only to anxiety and actually usually in most cases do not have much clinical relevance. So the MRI worked better in both aspects. It diagnosed the cancer which needed to be diagnosed. It diagnosed less of the cancers which need not be diagnosed. Okay. Then we did a similar study across 4 institutes, and this is one of the largest studies in patients who had a biopsy, a regular office biopsy. I'm not sure what's happening. Who had a regular biopsy and it was negative. Then MRI was done and repeat fusion biopsy was done to find the cancer. And in these patients, if you see regular biopsy, even in patients who had multiple negative biopsies, diagnosed a lot of cancer. But if you see the clinically significant cancer detection, regular biopsy hardly diagnoses clinically significant cancer as compared to the fusion biopsy, which is the red line. So the red line is higher for clinically significant cancer, and blue line, which is systematic biopsy, is lower. So regular biopsy does not detect as many clinically significant cancer as the regular biopsy.
What is a fusion biopsy?
So the fusion biopsy is a biopsy technique where we use MRI information. Patients first get an MRI, and is that what's working? Patient first get an MRI, and MRI identifies abnormal areas, and using that MRI information and a machine called fusion machine, we use ultrasound information from the office, combine both of them together, superimpose MRI information on the ultrasound information, and then target those areas. So because ultrasound would not help us identify any abnormal areas. The only role of ultrasound in biopsy is to tell us this is the prostate. That's it. It does not tell us if this is abnormal prostate, is it cancer looking prostate. It's the MRI which gives us that information, and that's why fusion biopsy, where we combine MRI and ultrasound, helps us diagnose and target those abnormal areas. And more recently, this is a level 1 evidence. Level 1 means the highest scientific evidence you can have for anything. Level 1 evidence for MRI, prostate MRI. This is a study done again from Europe, where they had 576 patients in 11 centers in UK, and all of them got prostate MRI, followed by a regular biopsy, and followed by something called template biopsy. It's template biopsy means they biopsy prostate 60 times. Okay, so it is equivalent to getting prostate in hand. They want to know every single cancer. They want to know if this is a prostate, they wanted to know wherever the cancer is, what's the grade of the cancer, the location of cancer. So the best way is to take the prostate out, right? But you're not taking prostate out for these patients. So the other alternative was to biopsy that prostate 60 times and figure out whether what's the actual picture in the prostate. And they compared that actual reference value to prostate MRI and to regular biopsy, where you get 12 cores. And they found MP-MRI found 93% of the cancers, while biopsy found only 48%. Okay, so that's one advantage of MP-MRI. But the biggest advantage, and a lot of even urologists do not understand that, and I argue with them all the time, is not that we found more cancer with prostate MRI. The advantage is when you use MP-MRI first, if you have elevated PSA, you go to doctor's office, your doctor orders an MRI. If your MRI is clean, then you don't need biopsy. And these guys showed it in this study, and then they showed it study published last month in New England Journal of Medicine, that 27% of the biopsies can be avoided. In US, we do 1 million biopsies a year. You avoid 27% of the biopsies, that's 270,000 biopsies that can be easily avoided because these guys did not need biopsy to begin with.
What's the cost of the medical system for a biopsy roughly? Do you have any idea?
No idea, but I think since they don't need anesthesia, I would still think it's gonna take professional fees and everything included will take 3 to 4,000, and MRI itself is comparable cost, and people used to argue against MRI that you're getting an MRI and then getting biopsy, so it's double the cost, right? But the advantage here is you're avoiding 27% of the biopsies. The second thing is you don't have to do the repeat biopsies. Prostate MRI followed by biopsy will give you the clear picture at the first biopsy. You do not need 1, 2, 4 biopsy. The paper which I published recently had a guy who had 16 negative biopsies before he got prostate MRI. So that's how people used to be. When I was a resident at VA, we had these guys coming every year. We would biopsy them, no cancer. Come back next year, PSA is again high. We biopsy them, no cancer. So this was reality. We kept biopsying them because their PSA kept rising, and we couldn't identify cancer. Probably because the cancer was in the area which was not traditionally sampled. When we do office biopsy, we biopsy only 15 to 20% of the prostate. So if you're lucky enough that your cancer is in that area, we'll find it. If not, then you come next year, your PSA is rising because you have prostate cancer, we biopsy them again. So that's how the norm was until prostate MRI came into the picture.
There came a point where you had to validate the MP MRI against something else that you had a lot of confidence in, but you want to go with the MP MRI if possible because it's more efficient or maybe less expensive. But of those 27%, how many false positives or false negatives were there with an MP MRI?
So we don't know there were any there's no false negative. So the true reference value to validate whether MRI and biopsy work is actually to take prostate out and take a look of entire prostate in a microscope, right?
So in this case, you MRI'd them and then took the prostate out?
They did not take the prostate out.
Okay.
That's why I'm saying the alternative for not taking the prostate out was to biopsy prostate 60 times. They biopsy prostate 60 times, and that's their gold standard. They said this is a technique which will find all the cancers as good as taking the entire prostate out and looking at a microscope. They biopsied it 60 times. They compared that gold standard against prostate MRI and against regular 12-core biopsy. So compared to that gold standard, MP MRI found 93% of the cancers, while regular biopsy found only 48%. Okay. And finding more cancer is to some degree an advantage, but it's not advantage of MP MRI. The biggest advantage is if they would have gotten just MRI and not biopsied these guys, 27% of the patients would not have gotten biopsy at all. And MRI was negative in these patients, right? So if you use MRI, these patients got biopsied because they're trying to prove a point. But in true scenario, if you had a negative MRI, you do not biopsy, 27% of patient might get not biopsy. You'll miss some cancer. So in this study, it was around 5 to 6% of the time they missed cancer by not biopsying the 27% of patient. But it's only 5% chance. If I tell my patient all the time when they're negative MRI, I tell them there's 5 to 10% chance that you have significant cancer and I'm not biopsying you. Are you okay with it? Most people are okay with it. But if I have a 50-year-old with a negative MRI, I'll tell them do not take that 5% chance. If I have 70-year-old with negative MRI, I'll tell them it's 5% chance it's going to be okay. I don't biopsy them. So you have to use your judgment at that moment. But the chances of MRI to miss cancer, completely clean MRI to miss a significant cancer is 5 to 10%. 10 is the highest any study has shown. Most studies have shown in the range of 4 to 5%. The NIH data showed 4 to 5%. This study showed around 5 to 6%. So most studies have shown around 5%. That's the number I quote when I don't biopsy somebody. But these are guys with elevated PSA. If you would not have got an MRI, they were getting biopsy. Everybody above PSA over 4, we were biopsying them. Now, 27% of those patients we can avoid biopsy with the risk of not diagnosing 5% of the cancers. But all those 27% of patients might have some Gleason 6 somewhere. Then you're worried about putting them on active surveillance. Then they come back next year, you get their PSA, then you repeat their biopsy. Then there's so much anxiety. Some patients end up getting surgery, some patients end up getting radiation because there's so much anxiety of word cancer. right? Even though Gleason 6 doesn't kill doesn't kill all of them, but just the word cancer creates so much anxiety. And it's difficult to actually sometimes not treat these patients than to treat this patient. I had a cop come to my multidisciplinary clinic referred by Dr. Donovan because he was not getting convinced by Dr. Donovan for not doing anything on Gleason 6 cancer. He had a Gleason 6 cancer. I had to spend an hour to convince him not to get treatment. And I am fortunate that I'm in a place, academic center, I have that much time. I can spend, because my time usually, our compensation is not time, money is not like directly proportional, right? But if you're in community, there's no way somebody's gonna spend an hour time to tell patient you do not need treatment. If patient says, I'm anxious, they're gonna say, okay, let's do your prostatectomy tomorrow. So, and that still happens. Even now, more than 50% of patients with Gleason 6 end up getting treatment. There is some monetary benefit for the doctor and there's anxiety from the patient. And they decide, okay, let's get the treatment. It's win and win for each of them until they have leakage and impotency. Okay. So we established that MP-MRI, prostate MRI, is the way to diagnose cancer. And then for the purposes of focal therapy, does the same technique identify that the culprit lesion, the lesion which will ultimately, if not treated, can lead to patient's death? With the MRI diagnose that. And this study showed that MRI's capability to diagnose it is very high, around 90 to 96%. So rarely you'll miss that big tumor with MRI. And that has given to the concept of image-guided focal partial gland therapy. So focal therapy is not new. There have been doctors trying focal therapy even before MRI. Because the MRI wasn't available back in the past, they were treating patients based upon that 12-core biopsy, which is very, very inaccurate in terms of deciding the location of the prostate. And that's why the outcomes were really, really poor. Patients were having aggressive disease and their PSA kept rising, and they end up getting prostatectomy. So that focal therapy never became popular, even though doctors were doing it. But since the MRI came, focal therapy has gotten like now new popularity because now you can better find that cancer and treat it than with the 12-core biopsy. So once you identify the cancer, you know the culprit lesion, you know by destroying it, you can essentially take care of all aggressive cancer in this patient. How do you do that? So there are multiple energy modalities you can use. And that's where there's a HIFU, there is focal laser, there's a focal cryo, there's even focal radiation to destroy the cancer. As long as you can destroy that spot, your purpose is achieved. So what we do at UC are two techniques. We use cryoablation, which is freezing of prostate. It is a cancer treatment modality. It uses freezing temperature, and by using freezing, it kills the prostate and the prostate cancer with it. This treatment modality has been around for 50 years. Again, this is not new. The way we use it is new. And the way it kills cells is, it just freezes the cancer cells and bursts it and spills all the content of the cancer cells. That's how it kills cancer cells. It also takes the blood supply from the cancer cells, and cancer need blood to grow, to get food, and this kind of stops cancer cells.
Does it actually disrupt the DNA or RNA in the membrane?
It does. It breaks
so
the cell membrane.
Cells later on.
Yes, exactly. Unless you leave some cancer cells behind, right? There will be some resistant cells.
Raw DNA, raw NRA, they're all disrupted as well.
For the cells which are destroyed. Yes, sir.
Doctor, how do you control the freezing of just the cancerous lesion versus the surrounding parts of the prostate?
And I'm going to address that. And that's a problem. That you're right. That how do you do that? So I'm going to show you in a little bit. So the advantage of this is it's minimal invasive, minimal morbidity. There are no cuts involved in the body. There's 2-hour long procedure, unlike surgery, which is 4 to 5 hours long and cuts in the body. There are no cuts. There are some needles going behind the area of scrotum, and it varies depending upon how much prostate you're trying to freeze. If you're trying to freeze small amount of prostate, then there are just 2 needles. If you're trying to freeze entire prostate, then 6 needles. But these are just needle pinpricks going to your prostate, freezing it and killing your prostate. So how do we control how much prostate destroyed? So these are the needles which we use. They run through them some gas called argon and helium, and using that combination of gas, it caused the freezing of the prostate tissue. And they're different needle sizes, and they induce different amount of freezing. And they know the guys have done this in pigs and dogs, and they know these companies know how much freezing will it induce. So the dark blue is the area where the temperature drops down to minus 40 Celsius, minus 40 centigrade. That's the kill temperature. And the light blue is probably not kill temperature. It'll kill some cells, but it will stun a lot of cells, and some of them will survive. So you want your cancer to have that dark blue area. And when you use multiple needles, these ice balls, they combine to each other and create a bigger ice ball. So when ice destroys tissue, it always creates a ball. And that's the problem sometimes with focal therapy, because you want to create it's not going to conform to the boundary of prostate, it just creates a ball, right? And whatever comes in way of that ball gets destroyed, whether it's your nerves, whether it's urethra, whether it's sphincter. And that's where the complication came. But we know by using the needle here, needle there, how much destruction we can get and how big an ice ball we're going to get. We know that now because we've done so many of these over years. Not me per se, the urologists have done so many of these over the last 30 years. So we know how big an ice ball will get generated by using combination of these needles in that location. Okay.
Two
And-
questions. Do
yes.
you have real-time observation of
Yes.
how big it's becoming?
Yes.
And
So
what's the relationship of UC to Healthtronics?
not really. I just use there are only 2 companies. There's a Healthtronics and Galil. Before I came over here, UC was using Galil. My preference or what I'm trying to do is Healthtronics, because Healthtronics they have one needle in which you can actually change the size of the ice ball. So you don't have to put multiple varied needles. It's one needle, and you can actually change the size of ice ball in that needle. So it gives me more flexibility instead of having 2 options with other company where they had only 2-3 options. One give this size ice ball, second give this size ice ball, third give this size ice ball. With Healthtronics, I have one needle and I can vary the ice ball size depending upon how much destruction I want.
And do you inject a foreign substance, or is it just by coming in contact with the coldness of the needle?
For the coldness of the needle, the gas runs through the needle and it's so cold that it destroys the cancer cells. Anything which is in that blue range dies. And the failures are sometimes not everything falls into that blue range, right? Difficult to control an ice ball. It's a sphere. It's not shaped according to the prostate. It's going to be a circle. The other reason there's a failure is ultrasound tells us there's an ice. It does not tell us if it's the dark blue ice or light blue ice. So you would think the entire prostate frozen is dead, but it's possible parts of frozen has only reached temperatures of minus 10 or minus 15, which is not enough to kill sometimes. It may stun cells, but it may not kill cells. When we're using, so this modality we'll be using for years for destroying the entire prostate. And again, the rationale was we did not know where the cancer was. So the safest thing is to destroy the entire prostate, like it was to take the entire prostate out. So that's what we're using this modality for cryoablation. But now, over the last 7 to 8 years, we've been using it for focal cryo. Again, a lot of this data is pre-MRI. The patients were diagnosed using varied techniques. Some people used MRI, some people used just 12-core biopsy, some people used 24-core biopsy to get better idea of prostate cancer in the prostate, and then using their own mental calculations did the focal cryo. Okay, so the newer numbers will definitely be better than these numbers where we be using MRI. So this is the largest database in US called COLD, and it had 317 Gleason 6 and 166 Gleason 7 patients who had focal cryoablation. And the freedom from PSA failure. Now, unlike prostatectomy, where you take the entire prostate out, your PSA should drop down to 0. Any PSA is cancer recurrence, right? Prostatectomy is straightforward. Prostate goes, with surgery, prostate goes, your PSA drops down to 0. If you have any PSA, it means you have cancer somewhere. With this, you're not destroying the entire prostate, you're destroying only the cancer. So the PSA never drops down to 0. It's always there. So we come up with a calculation to figure out when would we say it's a failure. So there are multiple formulas, and by one of those formulas, in these patients who got focal cryo, after 5 years, 70 to 73% of them were free of that PSA failure. So the comparable number for prostatectomy is 85. So definitely lower than prostatectomy, but much more safer, and we're going to discuss that.
You mentioned Gleason 6 and 7. Are there people, just for the overall scheme, that with Gleason scores are say at 10 that you're not even going to offer this procedure to them? It's not practical, or?
Yeah. 8, 9, 10, probably nobody's going to offer focal therapy at this point. And actually, I am actually going to offer through a clinical trial, but that's something we discussed last time. We don't have that on the slide. It's an experimental protocol where we're going to offer focal therapy in combination of some systemic therapy for patients who are metastatic disease. But that's completely experimental. And the continence is pretty impressive. So you do not get that with prostatectomy. It's 95 to 99% of the patients were dry. They were not using pads. And even though freezing is pretty bad for the nerves, but since it's focal, you're destroying one part of the prostate, you're definitely leaving the nerves on the other side of the prostate. Good 46 to 69% of patients were potent at 2 years. So the comparable number for surgery is in 40s, in expert hands. And we're talking about focal cryo in an era done where MRI was just coming up. Okay. And the most dreaded complication of any ablation procedure is destroying the rectum. And they found out that risk is 0 to 1%, so pretty low. Then the next treatment modality is HIFU. HIFU is new. It's very popular in Europe. Almost everybody gets HIFU there now. It's not as popular in US because the insurance doesn't reimburse it. Only it was available until recently with cash pay, and people were being charged $25,000 for it. The way it destroys cancer is through this ultrasound probe. It generates some waves which goes into a prostate and destroys the prostate by heating it up. The advantage of HIFU is there are no cuts involved in the body at all, not even needle pricks. This procedure goes into, this probe goes in the rectum while you're asleep. It's 2-3 hour long procedure. Wake up, no incisions at all. You go home the same day. Much less invasive than prostatectomy. And it kills by burning the prostate. And there are 3 different ways it kills cancer cells. First burning, and then shaking cancer cells so aggressively that it breaks, and resulting into a lot of cancer death and inflammation. This is one of the first trials, actually the first trial on focal ablation in the MRI era. These guys used HIFU to do the focal, and this again from London. All the focal stuff is coming from UK and Europe. US was lagging behind because there's some urologists who were getting incentivized by doing prostatectomies. While in UK area, you have fixed salaries, and there are multiple reasons, I'm not sure why, but but the government pays for HIFU, while here insurance agencies pay for HIFU. So they have been experimenting with this modality for the last 8-9 years, and it has become so much popular there that prostatectomies are becoming less and less popular in Europe. So they used MRI and did the first study for focal HIFU. They were heavily criticized in US, partly because we did not believe that this thing can even work, and secondly, we did not have this, right? So they enrolled patients with PSA less than 20, Gleason score either 6 or 7, which is 3+4 and 4+3, and they used this machine to deliver HIFU. Since it was new, they want to see how bad are the side effects, and the second outcome was, are we curing cancer or not? They found out that the side effects were really minimal. Even at the end of 1 year, 76% of people had erection. That number is so high, you never see that number in prostatectomy or even radiation patients. And 86% of the patients at the end of 1 year did not have clinically significant cancer. They had cancer, they had Gleason 6s, small Gleason 6s, but if you take clinically significant cancer, which is Gleason 7 or higher, 86% of them did not have it. So by doing a 2-3 hour long procedure with no invasiveness, this is not minimally invasive, this is non-invasive procedure, they found out that they almost took care of 86% of clinically significant cancer. So since that trial, HIFU is getting more and more popular in Europe, and in US now, Medicare has approved part of HIFU, but still there are significant out-of-pocket costs for the patient. It's not like cryoablation or prostatectomy or radiation, which is covered by insurance entirely. Only part of HIFU is covered by Medicare. So who do we offer focal and partial gland treatment at UC? The most important thing is motivated patient. This is not end all. This is not prostatectomy where you remove the prostate and you're done. You see your physician every 6 months with a blood test and that's it. This is a treatment which definitely requires much more involvement. Your cancer, even if the cancer gets completely treated, you have still 70 to 80% of the prostate remaining, and that prostate can form a new cancer. So we need to diagnose that cancer. So motivate patient, multiple visits until of course they turn 75, where we stop screening for prostate cancer, and periodic MRIs, periodic possibly biopsies. So it requires a lot of motivation on the patient part, and they need to understand there's a need for intense follow-up. What are the cancer criteria we use? We offer this treatment to patients who have an MR visible lesion. So on MRI there should be something visible, and when we do biopsy, there are only Gleason 7s which we offer this treatment for. I feel like 8, 9, 10 is so high risk that for those patients it probably is slightly under treatment. 6s on active surveillance, I think they do not need treatment at all. And for offering them this, it's only treating their anxiety. It's probably not treating their cancer. The cancer doesn't need treatment. Only Gleason 6s which we are going to treat are where there's a lot of Gleason 6 in a young guy, where it might matter because you might lose some Gleason 4 in that Gleason 6. So only those Gleason 6s will be treated, but mostly it's a treatment for Gleason 7, intermediate risk prostate cancer, not for high risk, not for low risk. And when we plan the treatment area, there should be absence of Gleason 7, which is a clinically significant cancer, outside the planned treatment area. And I'm going to show you some schematic diagrams of what treatment area looks like. There should not be aggressive cancer outside of that treatment area. Small amount of Gleason 6s is okay. We've been offering treatment to patients destroying their Gleason 7s and leaving some Gleason 6 outside or on the other side. If you destroy left side, on the right side we left some Gleason 6s, that's okay, because that's like putting patient in active surveillance. But patient needs to understand that this is, and you'll still be a prostate cancer patient, your prostate cancer is not cured. We just destroyed the most significant threat to your life. And PSA less than 15 nanogram per ml. Ultimate goal of this treatment compared to prostatectomy is to have better functional outcome. So there has to be a way to save the nerves of erection. There are two nerves of erection. One goes on the left side, one goes on the right side. So if by destroying cancer using focal treatment, you're destroying both left and right nerves, then you're not achieving the purpose. And it should avoid injury to the urethra and sphincter. So the whole goal is to preserve functional outcome while controlling cancer. It's not a cure of cancer, it's a control of cancer, which is sufficient in most patients because they don't die of prostate cancer in this category to begin with. They potentially can die of prostate cancer, but as long as you control the most aggressive disease, they're less likely to die of prostate cancer. And this treatment is a good treatment modality for patients who fail radiation. There are a lot of patients who fail radiation, and radiation oncologists start them on hormone therapy, which has a lot of side effects. It causes fatigue, it causes mood changes, it causes hot flashes. It essentially puts patient into male menopause. So by using focal treatment, you can avoid that systemic therapy. You can avoid that shots which patients get every 3 months. So what are the treatment planning we do? So that the reddish lesion is the aggressive cancer, clinically significant cancer. The green is less aggressive cancer, Gleason 6, right? So for pure focal, we would destroy just that aggressive cancer. And if you see, more than 80% of prostate is left behind. So the side effect profile of this is very minimal. Patient get this procedure in 2 hours, they wake up, they go home. They have a catheter which comes out next day. Compared to 7 days for prostatectomy, compared to 1 or 2 night hospital stay for prostatectomy. And you achieve the same purpose because with MRI now we're confident, we know that in that blue area there is no significant cancer. The odds of missing a significant cancer in that blue area is only 5%. And most patients are okay with it because they get to preserve their erections, they get to preserve their continence. In patients where there's a little bit more disease than just that one culprit area, we do hemiablation, destroy the entire left side. It's okay to leave some Gleason 6 cancer on the contralateral side. And then the third thing is quadrant ablation, which I think I use the most, destroy almost 25% of the prostate, taking care of any cancer in that area. But the main reason is to destroy that big bad lesion. Okay. All those, you see those dots on the side of the prostate, those are the nerves. So the whole goal is to preserve one nerve. So patient has some erectile function compared to prostatectomy, where when we're trying to peel the nerves off, even though we tell patients we're peeling the nerves off, in that process you're still inducing damage to both nerves. While in this case, one-sided nerves are completely untouched, and that's why it results in better sexual function. So now we have 2 modalities. One freezes, one kills, one burns. How do we choose which patient is going to get HIFU versus which patient is going to get cryo? The first thing to decide is prostate size. HIFU works only if your prostate is less than 40 grams, which a lot of Americans have bigger prostate than that. HIFU, in one machine, there are 2 HIFU machines. One machine works only with prostates less than 30 grams, other machine works in prostate less than 40 grams. So if your prostate is bigger than that, you will not get HIFU. Cancer location. HIFU doesn't work as well on the anterior cancers. Cancers over here, HIFU doesn't work as well. So for those cancers, we offer freezing. Freezing works better. For these cancers, both HIFU and cryo works well. But if there's a cancer over here, which is close to the rectum, again, ice ball is difficult to control. It's a sapphire ball, while HIFU is a pinpoint burning. So we can control that burning very well, while ice ball is gonna form a ball if you want to destroy the cancer. And just behind prostate is rectum, and freezing can freeze the rectum and create a hole in the rectum, which is a big problem to deal with. And that defeats the whole purpose of doing this treatment to begin with, if you're going to create complications, right? So any lesion over here gets HIFU, any lesion over here gets cryo. On all other areas, you can do both HIFU and cryo. And functional outcomes help us decide. If you have bad erections to begin with, then cryo is a good treatment modality. Erections, you don't have erections to begin with, it's not going to go into negative, so you can freeze it. While if somebody is young and has really good erections, HIFU gives us a better control and more pinpoint accuracy to destroy the cancer without destroying the nerves. But the final thing is affordability. And cryoablation has been around for 40 years. It's approved by all insurances, and the out-of-pocket cost for patient is usually minimal. It's usually their deductible, no extra cost. While HIFU is approved partly only by Medicare. Nobody else has approved HIFU. So if you choose HIFU, and a lot of people choose it because of lower side effect profile, at the minimum out-of-pocket cost will be $5,000 to $10,000. And if Medicare doesn't approve it, sometimes Medicare says yes at the beginning and then refuses to pay the money, you're going to end up having a charges close to $25,000. So any place in 2018 people are going to get HIFU, they'll have to pay $25,000 upfront, or at least half of that upfront, because Medicare may say yes first and then would not pay the money. Okay, so that's definitely an important decision to decide whether cryo versus HIFU. But those are the advantages. Cryo freezing kills cancer slightly better than burning it, though. That's the other thing people need. If you're 50-year-old, where saving erections is way more important than dealing with a little bit of residual cancer, which you can get repeat HIFU 4 years later, 5 years later. Sorry. Then, and you're ready, and you have money to pay $25,000, then most likely that patient is going to go for HIFU. But if you are 70 years old, where saving erections is probably not that important for some patients, then cryoablation is a better modality in a way that it destroys cancers, and the chances of repeat procedure is slightly lower. But none of them is perfect, and so is prostatectomy, so is radiation. Nothing for prostate cancer is perfect, but you need to find a physician which will give you options and gives you risk and benefits of all these. And it should be a patient decision, not a physician decision, because so far, despite all the research we have done, there is not a single study which shows that you treat prostate cancer versus you do not treat prostate cancer in a large number of patients, you make difference. There's a one large trial done at US called Pivot trial, done in VA hospitals, where they took 700 men, said 350 men, we're gonna not treat your prostate cancer, you go home and come back if your prostate cancer has spread to your bones, and then we'll just treat you then. Other 350 men, they said, okay, we're doing prostatectomy on you tomorrow. They did that. They looked at this man 12 years later. There's no difference. The risk of death is almost comparable. So this is a cancer where there's a real risk of over-treatment of this cancer, and that's why we'll have to be cautious as a field, as a urologist, that we do not put extra morbidity on patients for a cancer which may or may not kill them. And nobody knows the best answer for this. So in conclusion, focal ablation of prostate cancer is safe and feasible. encouraging short-term outcomes. This is not a treatment modality for which we have 30 years worth of data, like prostatectomy. This is new, so there is risk involved with anything new. But one thing we know is the functional outcomes, which is erections and leakage, is much better with focal than with radiation or than with surgery. And it's possible in 2018 because of prostate MRI. It helps us find the lesion well, and that's why for me, even patients, insurance approves MRI if you had one negative prostate biopsy. It sometimes does not approve MRI if you never had prostate biopsy. But for all my patients, they get MRI upfront because you want to know where the cancer is, if the patient will be candidate for radiation, surgery, or focal. And MRI has also facilitated the follow-up after focal therapy. However, there is a scarcity of long-term data. The longest study is around 7 to 8 years old. And for prostate cancer, 7-8 years is nothing. Patients don't, even if you don't treat prostate cancer patient, they're not going to die in 10 years. So to actually see the benefit, the study should be around 15 years long. And this modality has not been around for that long to have that much data. Okay. And that's why we need to do more research to find which are the patients which are going to benefit from this treatment modality and which are the best candidates for this treatment modality. Thank you.
The next slide has some questions that people have emailed in, if you don't mind looking.
Cool. So we haven't done any HIFU. It just got recently approved. We have done several whole gland cryos, even as a training. We have done only 2 focal cryos. And the way we do focal cryo is the same way we do fusion biopsy. And this technique is new. We had fusion biopsy for 3-4 years where we have an MRI, we have a regular ultrasound, we superimpose MRI with ultrasound, create a 3-dimensional model of each, and make sure they align each other. So anything seen on MRI appears like a red dot on ultrasound, right? Ultrasound cannot tell us the lesion per se, but because of MRI and radiologists have marked that problem area as a red dot, you see the red dot, you put a needle through that red dot. That's how we do biopsy, fusion biopsy. So we did have that technique for biopsy for a long time. Only recently, the fusion machines are coming with a platform where we can use the same technique for targeting and destroy. So the way we do focal now is we create a 3D, we have 3D MRI model. We create a 3D MRI model in the operating room with ultrasound. We superimpose. Dr. Verma marks the cancer area, and then she also marks a healthy margin of normal prostate around it. And the reason we destroy normal prostate around it because MRI underestimates the prostate tumor volume. So if MRI tells you that tumor size is 12 millimeter, right? A lot of time studies have shown that it's not 12, it's 14 or 15. So most clinicians will destroy 25 millimeter to just be on a safe side, okay? So Dr. Ahmad had done HIFU for over 6 years, yet there's only data for 12 months. Good question. The reason it's for 12 months, because those are all clinical trials. This group has done with urology, which no other group in the history of urology has done. They are really productive in running clinical trial and producing good science. So they try new things, and they don't have any data on overall survival, which will take 20 years to get, right? How long patients are actually living with this? We don't know that. Are they living any longer than prostatectomy? Are they living shorter than prostatectomy? We don't have that data because they haven't done that. They haven't followed this patient. These are initial feasibility studies just to prove that this thing works. And you don't need more than 12 months to prove that, right? If 12 months later there's no cancer in the site where you destroyed, you have proven it. And they've also proven that in 15% of the patients, there will be cancer there 12 months later. So we know this treatment works only in 80 to 85, sorry, 80 to 85% of the patients. In other 15% of the patients, you have to undergo second round of HIFU or second round of cryoablation. That's the HIFU is now available real-time MRI thermography. When will this available at UC? Probably never. I'm running the HIFU program. For MRI thermography, you need to be an MRI machine, right? When you're an MRI machine, it's just not an easy way to do things. Operating room is much more easier, and it would help us out a little bit that it'll tell us actually HIFU is destroying cancer or not. And if there's an easier way to do that, we'll probably adopt it, but it doesn't seem like it's gonna happen anytime soon. Also, you have to see, unless insurance approves it, this modality is not gonna pick up a lot in US. $25,000 is a lot of money for most people. And anybody below 65, a penny is not covered by insurance. It's all $25,000 coming out of your pocket, which is okay if you are 50 years old and want to preserve your erection, and then it's totally worth spending the $25,000. But I don't see a lot of 70 years old would spend $25,000 to preserve really weak erections they have. Let's accept it. 70 years old, the chances of having really strong erections is pretty low to begin with. And I'm not sure if it's gonna get really picked up until insurance approves it. So it's gonna take a couple of years before that happens, and then probably that'll happen. So not anytime soon. Do you treat Gleason 6 cancer? I do not. I do not treat Gleason 6 cancer. Is Gleason 6 cancer that surrounds Gleason 7 or greater cancer treated differently? So if you're getting prostatectomy for Gleason 7 cancer, then you're treating Gleason 6 cancer. If you are getting focal therapy for Gleason 7 cancer and there's a Gleason 6 cancer nearby, it'll get treated. We'll treat that. We'll just have to expand. So as long as you're destroying one nerve already, then to destroy, instead of 25% of prostate, destroying 35% of prostate, it would not make any significant difference in side effects. Side effect profile is going to be the same. Side effect profile changes when you destroy both nerves. As long as you have Gleason 6 cancer close to your Gleason 7 and we're destroying one nerve, by destroying a little bit extra prostate tissue, it would not change anything in terms of functional outcomes, and will be a little bit better oncologically. By oncologically, better cancer control. If somebody has Gleason 7 cancer on left side and a big Gleason 6 cancer on the right side, we would not offer them focal therapy to begin with. And what's the definition of big? That differs between surgeons. Some people think greater than 5 millimeter is big. Other people think any amount of Gleason 6 is not big, regardless of how big it is. The trials which Dr. Ahmad published, in those trials he has used 5 millimeter as a big Gleason 6. He would not offer focal therapy for somebody if there's a 5 millimeter Gleason 6 on the contralateral side. But he treats patients off protocol, not on the trials, where he leave a lot of Gleason 6 alone. Let's accept it. If this patient did not have any Gleason 7, just a 1 centimeter Gleason 6, nobody would have operated on that patient anyways. They put them on active surveillance. So it doesn't change anything even if they have untreated Gleason 6 on the untreated side. Okay. Anything else?
Want some water?
I'm good. I think I'm good.